I will start the meeting. Okay, are you ready, Ani? Rajasekar? Okay, Jai.
Ready when you are.
Yeah, okay. 5, 4, 3, 2, 1. Good evening, my dear brothers and sisters. I have great pleasure in welcoming you all for the Masterclass Hypertension Webinar Series Part 2. Today is the first day. And in fact, all of you might be happy. Today is auspicious day, Gandhi Jayanti. Today is Gandhi's birthday. So on this auspicious day, we are starting the Hypertension Part 2 webinar. So he's the one who did a lot of things for us. And I believe sentimentally, today we are starting with the blessings of Mahatma Gandhi. Now, I'll introduce the speakers and the panelists for the program today. All of you know the topic today is hypertensive heart disease. Last month, we had 10 webinars. Now, this month, we are going to have 12 webinars. So this is the first webinar for the series number 2. These are the webinar which we are going to conduct. Please make a note, block your dates. The opening batsman is Joy. He's like Rohit Sharma. All of you know he's very, very good. And along with him, Dr. Narasimhan is going to bat tomorrow. And one down is Dr. Chenniappan, whom all of you know is like Virat Kohli. So like that, we have up to 12 programs. On World Hypertension Day, we have an international speaker where he is going to talk on preclinical assessment of organ failure. So ladies and gentlemen, kindly note these dates and block the dates. Every Friday, Saturday we have, except this coming Tuesday, Chenniappan, again, next Tuesday also Chenniappan. So except those 2 days, all the other days are Friday, Saturday. So he's going to talk on CCB confusion and ARB, aid to right blockers. The other topics are there for you to know and then block the dates. Okay. Now, let me introduce the first opening batsman, Dr. Joy Thomas. He's an interventional cardiologist as well as electrophysiologist, Department of Cardiology, Apollo Hospital, Vanagaram, Chennai. Incidentally, he's also my friend who studied in Stanley. So he's a very good teacher, a very good academician, good researcher. And he's going to talk to us on hypertensive heart disease. So you'll be happy to listen to him. Now, I am very, very happy to introduce my friend, Dr. Professor Hani Etiba. He's really a good friend of us. He's a good friend of India. He visits all our API meetings and he's a very nice human being. He's a consultant, interventional cardiologist, Vice President of Royal College of Physicians and Surgeons of Glasgow. And the hospital where he works is a state-of-the-art hospital. Very nice, beautifully covered. The sceneries, natural, background. So I visited his hospital. He's a very good host also. So please welcome Professor Hani Etiba, who is going to be our expert panel, who is going to also take part after Joy Thomas talk. And Chenniappan, all of you know, and I think a lot now new members have joined. So those of you may not know, Chenniappan is the one of the best teacher in cardiology and ECG. And last time the webinar, he was a speaker for 8 webinars, and he's going to be the panelist today and tomorrow, and then going to be a speaker on 6th. Dr. Rajasekar is our treasurer of ACP, and he's also a very great academician. He's every day engaged in WhatsApp, hypertension, ECG, academic body, clinical imaging. So whole night he only searches articles and posts every day morning in all the WhatsApp groups. He makes the academic body moving very interestingly and very fast. Now let me have some housekeeping announcements. This webinar, 12 webinars, the Tamil Nadu Medical Council has accredited and is going to give 6 hours. Dr. Sendil, the president, also happens to be in the audience, and he is an observer. So all of you who have registered, your names are registered, and we all have the details when you are logging in, when you are going out, and who is playing with Kahoot, who is also asking chat questions and all that. So this is a record. Fortunately, for the last webinar, so many people have applied for the Tamil Nadu Medical Council accreditation, but some of them did not give full details in spite of the fact that we were requesting them to fill in certain format. They did not do. So it was taking a lot of time. Even today, somebody had sent. So I think most probably today will be the last day. I will not wait some more days. I will upload the whole names on Monday. And when we upload the registrants, the Tamil Nadu Medical Council charges 150 rupees for each certificate. The certificate will go directly to your email ID, whatever email ID you have given. Even for people outside Tamil Nadu, you don't need to do anything. The certificate will come to you in your email ID. And you may have to take that certificate to your medical council and get accreditation from your council also. So to make the process easy, we have taken the burden. You see, to get the details and upload, it takes 7 to 10 days for my 2 secretaries, because each and everything needs to be perfect. Even if you have a dot or if you miss one thing, the system doesn't accept. So we have already tried and completed. So probably Monday we'll upload. So once we upload Monday, you may start getting your certificate from Thursday or Friday. And for every certificate, 150 rupees will be paid by us, and you don't need to pay. Again, coming back to this webinar, part 2, when you attend all the 12 webinars, you will be getting a certificate where you will be given 6 hours credit hours. During the time of submission of that 12 webinars on October 31st or November, we may have to fill all the details and pay again 150 rupees for each of you. We are very happy to sponsor or give on your behalf. Only thing we request you, we are taking so much of time. We are taking so much of time to get good speakers, international speakers. Today you are lucky to have Royal College of Physicians, Vice President Cardiologist, Dr. Annie Etiba, who is a very good speaker. Chenniappan is there. So many good speakers are there. Utilize this opportunity. We are spending so much of time and money, energy. We want you to use this opportunity and serve the community. That is why today, in Gandhi Jayanti Day, service should be your motto. Whatever you learn, please apply to your practice. Of course, we are spending a few lakhs of rupees for this program and for the last program also. So we are doing on your behalf. We are not charging. Many people offered that they will pay for the course, they will pay for that certificate. All that we will do. And this time, last time, we were not very strict. We were a little bit lenient. So we will be giving the certificate for those people who have applied for. But coming to the home blood pressure monitoring, it's very costly now. And also sending by courier is very costly again. So our committee will decide whom to give the home blood pressure monitoring. We prefer people who are very active in the COHIT, plus who are actively involved in chat. So we will observe who has come in the early part and then who was with us throughout, because some people enter in the middle and they leave immediately. So all those records we have, but we are giving certificates for them, but we'll analyze whom to be given for the BP monitors. Once we analyze, maybe it will take another 15-20 days for us to procure the equipment and send it to you. And some of them suggested to give to youngsters to motivate them to start hypertension clinic. So my idea is to promote hypertension clinic, hypertension specialist, hypertensionist. So that's why we are spending so much of money, energy. Please encourage us. And you are applied today and somebody has applied yesterday. They are sending a mail. What about my certificate? It's not that easy to get that way. It's very difficult. So please understand our difficulty. Please cooperate. You will get your certificate definitely if you have attended all the 10 webinars. And this 12 webinars, I request all of you to attend sincerely. And the Medical Council observer is there. He is also in our panel. So he is also seeing who are who are appearing, who are not appearing, who is logged in and all that. All the details are there. I request all of you to participate in COHET quiz programs and actively involve and take it to your practice. Okay, with this, the housing announcements are over. Now I'll go to the topic. Of course, the 10 webinars, except 9 webinars are already been uploaded. You know the procedure. You go to our ACP India website and you can download and click the meeting and courses, and you can download and see all the 9 webinars. People who have not attended the webinars can also go into the website and can have the pleasure of listening to Chenniappan and other webinars which we conducted in September. And coming to the World Hypertension Day, we want every one of you during this month do something for hypertension. You can speak to your friends or patients or doctors, and you can do some screening camps. You can do some awareness programs. All that you can let us know. We will try to help you, and we can provide you some platform also. We are planning to do 100 webinars. Already I have got 100 webinars confirmed. Now this program is supported by Sun Pharma. Last time it was supported by IPCA, so they are also doing 100 programs this month. So those of you who are interested to do any program, please contact us. We will give you some support in the form of slides, in the form of resource persons, in the form of platform. And you can do it for medical as well as non-medical. Already I had 10-15 requests, which I have obliged. Even the Bala from Kerala, the Kollam, he is also doing some few programs. Padma Gulati, Kadiresan, so many people have approached, and I think I'm very happy to see so many are interested. My idea is in the World Hypertension Day month, you must make a big noise about the silent killer and create an awareness among the doctors as well as among the public. That is my aim and ambition. That is why we are taking so much of money and time to create an awareness among the doctors first. Then, of course, we have WhatsApp Institute of Medical Science. We have 3 WhatsApp groups on hypertension hits, 2 clinical imaging groups, and 3 ECG groups. I'm happy all these groups are full, but I'm yet to see full of activities in each group. See, only very few people participate. I think all of you must participate, put your doubts, share some points, and make the WhatsApp group very interesting. This is a learning group. Please do not put any invitations, don't post any greetings, don't post any message. Even for example, the hypertension program details, I'm not posting in the clinical imaging or ECG group. It's only in the hypertension group. So it's purely for science. And as I mentioned earlier, those people who are very active in the WhatsApp group also will be recognized. So every month we'll select one person who is very active in each group. So now Kahoot is a quiz program game. This will be done after Joy Thomas talk, and each question you will give only 20 seconds. Those of you who have joined recently, please download the app Kahoot IT and then be ready once Joy Thomas talk is over. These are the announcements for the future programs. Now you must listen to Joy Thomas. Of course, anytime hypertension, you never forget about the importance of history and clinical examination. And especially when you have a fundoscope, when you have stethoscope, all that you will be very useful to judge and diagnose your hypertension, especially S3, S4, sounds, all that, and Brewy, all these things we can find out with the sound stethoscope auscultation. Now I request Dr. Joy Thomas to present his hypertensive heart disease presentation. Joy, you can now start sharing. We'll enable you to share the screen.
Yeah, can you see my slides?
Yes, Joy, go ahead.
Good evening. At the outset, I would like to appreciate Dr. Muruganathan, my senior from Stanley Medical College, for taking this wonderful initiative forward in educating the physicians and general practitioners about hypertension and its various aspects of diagnosis and management of hypertension. This is the second of the webinar series which Dr. Muruganathan sir is doing, and I'm happy to be proud and happy to be a part of it, and I would like to thank him sincerely for that. It's also a special occasion when me, as a fellow of the Royal College of Physicians and Surgeons of Glasgow, are able to give this talk in the presence of the Vice President from Glasgow, Dr. Hani Taiba. It's a real privilege. Thank you, sir, for being here. Now, coming to hypertensive heart disease. Hypertensive heart disease is not a single entity, as we will see presently. Now, as you must know, okay, as you know, hypertension just a few minutes back, Dr. Muruganathan told that hypertension is a silent killer. Very true. That's why I made that statement in my first slide itself. It is a silent killer. If you must know, there are 16 out of 100 Indians are hypertensive. And if you look at the statistics, in the year 2025, we will have 214 million hypertensives in our country, quite a big population. And as you know, from the latest guidelines revised in 2017 by the American Heart Association, the normal BP is a systolic blood pressure less than 120 and a diastolic pressure less than 90. And between 120 and 129, it is considered as elevated as far as systolic blood pressure goes, and from 80 to 89 as far as diastolic blood pressure. Over and above 130 and 90, it is high blood pressure, stage 1, then stage 2. And then a systolic blood pressure of more than 180 and a diastolic of more than 120 is considered as a hypertensive crisis. Now, I would like to show three main clinical scenarios to illustrate the problem of hypertensive heart disease. First scenario, you have a 63-year-old male. He's admitted with acute breathlessness and he had gone for a morning walk. So you can understand that this gentleman has been normal in the morning. And then he develops breathlessness because he goes for his morning walk, comes back with breathlessness. And on examination, you find that his cardiovascular system shows a S4. As you know, you have got the two sounds lumped up, S1 and S2. And if you have, along with S1 and S2, a third sound following it like lumped that is an S3, lumped that is an S3. To demonstrate S4, just put in this sound, tulubdub, tulubdub, tulubdub. So that is an S4 which comes just before the second sound. Now this gentleman came with respiratory fine crepes in the base of the lungs. On echo, his ejection fraction was 55%. He showed left ventricular hypertrophy. Biochemically, his troponin was negative. So what do we have here? Now this is a classical case. His ECG is not very much demonstrable for left ventricular hypertrophy, but you can see he has got T inversions right from V2 to V6, which is a little bit asymmetric, not clearly the symmetric type. You may think he has got an inferior wall MI, but it is only because of the axis deviation of the heart. Now, this is what we call as an accelerated hypertension with diastolic heart failure. So, in other words, a person with a normal heart comes with heart failure. It's a condition called as diastolic heart failure. Let us look at scenario number 2. This is a 67-year-old male hypertensive, and he has a hypertensive patient with acute chest pain since half an hour. And you can see the ECG is showing ST elevation in the inferior leads, that is in lead 2, 3, and AVF, clearly indicating an acute ST elevation, inferior wall, myocardial infarction. If you look at the leads 2 and AVF, you can see that the R wave is still preserved, showing that it is a hyperacute anterior wall MI, and he has got what is known as reciprocal changes. Whenever there is an ST elevation in the inferior lead, you can have reciprocal ST depression in V1, V2, and V3, which are reciprocal effects of the ST elevation in the anterior lead, in the inferior leads 2, 3, and AVF. So clearly, this gentleman has got a hyperacute inferior wall MI. He was taken up for primary PCI. You can see that in the primary PCI, his RCA is totally occluded. And after the primary PCI, we have managed to open it up fully. This is a case of a myocardial infarction. The next scenario is a hypertensive, I think gone a little further. Is a 62-year-old hypertensive lady presenting with palpitation and breathlessness. Now, this lady has been all right a few hours back, and then she develops breathlessness and palpitation. As you can see, that in the ECG, there is a tachycardia, there is a narrow QRS tachycardia with the QRS morphology of the same pattern of what you see during a sinus rhythm. Clearly, the ECG shows left ventricular hypertrophy by voltage criteria. We will come a little later to that. And if you look at lead 2 and look at lead 1, where you look for P waves, you cannot see a P wave. So this looks like supraventricular tachycardia, probably an atrial fibrillation, it's not an atrial tachycardia because there you will see a P wave, but since we don't see P wave, it's most probably an atrial fibrillation in this patient. So an arrhythmia is another clinical scenario which can happen in a hypertensive heart disease patient. So in a nutshell, all these three scenarios, that is a person with diastolic heart failure, a person who presents with ischemia and myocardial infarction, a person with a presence with arrhythmias, atrial fibrillation, or even sudden cardiac death. All these are clinical presentation of a person who has got long-standing hypertensive and developed hypertensive heart disease. So it is not just simple as saying that hypertension means only LVH. No, this LVH can lead to all these clinical scenarios. So that is very important to know. Now, let us look at this slide, which tells us in a nutshell what happens in hypertensive. So you have got a hemodynamic load on the heart in the form of a high BP, and that induces left ventricular hypertrophy. It may be by salt intake, it may be by catecholamine surge, it may be by angiotensin II abnormalities or aldosterone, and modified by age, gender, genes, and birth weight. All these can lead to, one is what we just told, ischemia, myocardial infarction, or they can cause features of congestive heart failure. This congestive heart failure may be of diastolic heart failure, which we just discussed as a clinical scenario, or it may be one where there is a reduction of ejection fraction of the heart, or what is known as heart failure with reduced ejection fraction or impaired contractility. And then you have got persons who come with arrhythmias, which may be atrial fibrillation, ventricular arrhythmias, and sudden cardiac death. So this is the entire spectrum of hypertension heart disease. Myocardial ischemia, impaired contractility, impaired LV filling and diastolic heart failure, and arrhythmias, atrial fibrillation, ventricular arrhythmias. So remember all this. Now, going on to what initially happens, what is commonly known, what is known as the left ventricular hypertrophy. You can see this picture in the middle of the slide. This is a person who has a section of the heart of a person who has no high blood pressure and is a normal heart. You can see this round donut shaped thing is the left ventricle. What you see here is the right ventricle. So this is the right ventricular chamber, and this here is the left ventricular chamber. So the left ventricular chamber, you can see, is the lumen is rather small. Now, look at this patient who has got concentric hypertrophy, a person with long-standing hypertension, the muscles have thickened and the left ventricular wall all round is thickened, and it is certainly much more than in the normal heart. And because of that, the lumen of the heart becomes smaller. Uh, as hypertensive heart disease goes on for years together, the patient's heart can get gradually dilated, and that scenario is known as a person with a dilated left ventricle with reduced ejection fraction who can go for congestive heart failure. In such a patient, you can see that the left ventricular wall, though not thinned very much, the left ventricular lumen is very much dilated, and you can see the right ventricular chamber is also dilated because of the after effects of heart failure caused by rise in the pulmonary artery pressure, and that is transmitted to the right ventricle in the form of right ventricular failure. So any thickness of the left ventricle above 15 millimeter is indicative of significant hypertrophy. In the concentric hypertrophy, as we saw in the picture, the lumen is small, and in eccentric hypertrophy, as you see in a dilated heart, it is the lumen is very much big. Now, this is a longitudinal section showing the same hypertrophy pattern and the normal thing in a normal heart and a left ventricular hypertrophy. Now, one of the commonest, of course, after clinically evaluating the patient, putting a stent and finding out if the patient has S4 or any murmur or any failure symptoms like an S3, one of the easiest investigations which has been available to us for more than 110 years is the ECG. It is available everywhere throughout the country, in even the smallest villages. And you can see how do we identify left ventricular hypertrophy in a patient. The simplest way is by looking at the S in V1 and the R in V5 and V6, as you can see here. And if the sum of the S in V1 and R in V5 or V6 is greater than 35, then it is ventricular hypertrophy. The other thing is by what is known as the Cornell criteria. If you're looking at only limb lead voltage, is where we look at the lead R wave. If the R in AVL is greater than 11 millimeters in a person with a normal axis, then it is hypertrophy. In a person who has got left axis deviation, the R in lead AVL plus, the R in lead AVL plus S in lead 3, if the sum of it is greater than 25 mm, then it is a left ventricular hypertrophy. In Cornell voltage criteria, I'm sorry, I used the word Cornell earlier. This is actually Cornell criteria, where the sum of the S in V3 and the R in AVL is greater than 20 in women and greater than 24 in males. It is left ventricular hypertrophy. So these are the various methods by which we diagnose left ventricular hypertrophy from the ECG. One is by looking at QRS amplitude. Second is the delayed intrinsicoid deflection in V6. I'll just show you what it is. Widened QRST angle and a leftward shift in the axis. Now, looking at intrinsic deflection, what intrinsicoid deflection means? In the QRS wave, the initial part, which is going with the active part, then starts relaxing and coming down. That point marked by the red arrow here is the onset of the intrinsicoid deflection from the active contraction. So this onset of the intrinsicoid deflection, if you put a line and take it to the baseline, and from the beginning of the QRS is known as the ventricular agitation. So the ventricle takes a little longer time to contract, the electrical forces take a little more time, and that is known as the ventricular activation time. And this is probably the negative in V4, V5, V6, and they're dominantly positive in lead 3, which means the T wave axis is switch off the video.
And then you
Now, if you have a prominent T wave, as you see here in lead 3, it indicates that the T wave axis is towards the right. On the other hand, the R wave is most prominent in lead 1 and lead 2. I'm sure Chenniappan would have taken you through these things of how to determine the axis. And you can see the QRS axis here is about 142 degree, whereas the QRS axis is 24, but the T wave axis is towards the right, 124. So 142. So the difference between 142 and 24 is certainly more than 110, which indicates a wide QRST angle. Now, left ventricular stain pattern is seen when in the lateral leads, you have left ventricular hypertrophy by voltage, tall QRS, and then downsloping ST with a T inversion with this asymmetric, and the terminal portion of the T just goes beyond the baseline. If you get a pattern like this with a downsloping ST, an asymmetric T inversion, and the final limb of the T wave going just above the baseline, then it is a strain pattern. So we have got these various criteria for left ventricular hypertrophy: the Sokolov-Lyon, Cornell criteria, Framingham criteria, and Rohill-Estes criteria. I don't want to go into details about this because it may be a little too boring, but I just want to tell you about this point score system, which has been popularized by Rohill-Estes. And what they have done is they have given score points for limb lead, ST wave, left atrial abnormality, left axis deviation, and QRS duration, intrinsic deflection, and given a score. So if there is a score of 4, then it indicates that there is left ventricular, probably. But if it is more than 5, it is a definite indication of left ventricular hypertrophy. Progression of inadequacy, supposing you don't treat the patient of hypertension adequately, then left ventricular hypertrophy gradually start, and this leads to gradual increase in the left atrial pressure as is seen here. But if the person's hypertension is controlled, then one can prevent this. Now, hypertension is associated with left ventricular remodeling and is one of the main determinants of diastolic dysfunction. Now, other cardiac diseases can also cause diastolic dysfunction, that is myocardial ischemia and other extracardiac pathologies related to the pericardium and also valvular heart disease. Ultrastructural features of hypertensive, the important thing is the extracellular matrix, which corresponds to fibrillar collagen, is important for processes of both contraction and relaxation. Myocardial remodeling causes changes in myocardial cells and also extracellular matrix. The renin-angiotensin system promotes fibroblast proliferation, altered collagen network, and increase in interstitial and perivascular collagen. Now, this is the picture. On this side, you get the normal heart. You can see the greenish thing are where the collagen elements are present. This is the myocyte. This is the coronary blood vessels around which you have the vascular smooth vessels, and then you have the cardiac fibroblast. So you can see in a normal heart how much of fibrillar collagen is there. But look at this. This is what happens in hypertrophy. The collagen element starts increasing in size and forming the major part of the extracellular matrix. And this is what causes the diastolic dysfunction in the heart. So diastolic dysfunction is not only by hypertension, it is also caused by cardiomyopathy, by coronary artery disease, systemic disease, and valvular heart disease. But look at this. All of these can cause LV abnormalities in LV relaxation. But only LV hypertrophy causes abnormalities in LV relaxation as well as an LV stiffness. which is not seen with the others. And both of these causes diastolic dysfunction and can cause heart failure in this patient. Now, there was a study which was published some years back, which looked at the exercise ability and LV filling in hypertensive patients. And you can see that as the exercise level increases, in a person with left ventricular hypertrophy, which are given by these blue lines, the yellow lines are those with no left ventricular hypertension. In a person who does not have left ventricular hypertrophy, even with exercise, the pulmonary capillary pressure does not increase much, above 20 millimeters of mercury. Whereas in a person with left ventricular hypertrophy, it quickly rises up. And this is what causes that exertional breathlessness in persons who have left ventricular hypertrophy, what is known as the initial stages of diastolic dysfunction. Looking at the hemodynamically characteristics of diastolic heart failure and hypertension in this study, which was published in 2008, it was seen that LV relaxation was more prolonged in hypertensive diastolic heart failure patient than non-hypertensive diastolic patient. And this is because of late systolic loading. And this is one of the causes for breathlessness in this patient. The other determinants of left ventricular filling is there are two major ones. One is the left ventricular has to relax, what is left ventricular relaxation. The other is it has to accommodate the blood by being compliant, what is known as effective chamber compliant. Now, these two are energy dependent processes. The relaxation is an energy dependent process, whereas chamber compliant is a passive property not dependent on energy, and it leads to diastolic suction, passive filling pericardium, and is restrained by the pericardium and ventricular interaction. So there are four phases of diastole, which I will just describe by this diagram. Now, this is the phase of rapid filling of the ventricle, what is known as the relaxation time. And then this is the rapid filling phase, where the pressure within the left ventricle fills up. Then you have the slow filling phase, and then at the end of it, you have got the atrial systole. So there are two components left. Excuse me. I'm sorry about the interruption. My throat started going dry. Need some water. And now, these are the four phases of left ventricular filling. So they initially, yeah, thank you. Thank you very much for being patient. So initially you have got the phase of rapid relaxation, and then you have got the rapid filling phase, then the slow diastasis, slow filling, and finally to cap it, you get the atrial filling, atrial contraction. Now, the patterns of mitral valve inflow reflects this four phases of the left ventricular relaxation. This component, what is known as the E wave of your mitral, this is done by pulse Doppler when you keep it at the tips of the mitral valve, and you do a pulse wave Doppler interrogation of the flow of blood from the left atrium towards the left ventricle. You get two waves. One is the E wave. The E wave is the rapid filling phase of the thing, which is caused by a passive phenomenon. Then it is followed by the A wave. The A wave is the atrial contraction causing the atrial filling. And in between, you have got the isovolumic relaxation time, in which the volume of the ventricle doesn't change. Only there is a relaxation without any filling. Now, when there is a delayed relaxation, as we saw just now in hypertensive patient, this isovolumic relaxation time is prolonged. What happens is the rapid filling phase decreases because of the reduced compliance. Oh, that is one thing. And the failure of relaxation of the, not failure, the slowness of relaxation of the ventricle, causing the E wave to be smaller than the A wave. And then when the pressure in the left atrium increases because of heart failure or all the things get reversed. The IVRT shortens, the E wave becomes tall, and the A wave becomes once again, but this is like a pseudo normalization pattern. Now, this is a picture of the actual Doppler transmitral index. You can see the E wave and the A wave. And in patients with heart failure, the E becomes small, the A becomes taller. And this is what we were just describing. And when you look at the pulse wave Doppler, which comes from the pulmonary wave into the left atrium, you have got the two waves which occur during the diastole. The initial one is the S wave during the rapid filling from when the ventricle is filling, and then you have got a little slower filling by what is known as the D wave, and then when the atrial contracts, you have got what is known as the atrial reversal phase. So these are the three important phases of pulmonary vein inflow, and you can see that in patients with heart failure, the S wave decreases and the D wave gradually increases, and the AR may become more prominent. Tissue Doppler indices is by doing tissue Doppler of the ventricular wall. You can see the colored thing from the ventricular wall Doppler movements, the color coding of the Doppler signals. And what in a normal person, the E wave is very prominent compared to the A, whereas in patients with heart failure, the depth of the E wave decreases, the depth of the A contradictorily becomes taller. So, in looking at diastolic dysfunction, what we have been discussing so far, the main cause of this diastolic failure in the heart is because of arterial hypertension. So it is blood pressure which is the cause of this. Although this has been identified as a separate entity, one must realize that hypertension gradually leads to this diastolic dysfunction. That is why hypertension is a silent killer and must be treated, even though initially the patient is not symptomatic because of hypertension. Overweight and obesity coexist with hypertension, deeply affects LV diastolic dysfunction, causing it to work overload. Increased insulin resistance is associated with prolonged isovolt and independent of LV geometric changes and of increased afterload. And all this is because of increased intracellular calcium. Now, it is one thing of controversy is whether left ventricular diastolic function necessarily accompanies the development of left ventricular hypertrophy, or is it independent of it? There are people who say that left ventricular hypertrophy need not be there for left ventricular diastolic dysfunction. But it must be seen that diastolic is a direct consequence of pressure overload. Even an elevated 24-hour blood pressure can cause diastolic dysfunction, and even more to increments of nighttime diastolic. So when there is increased nighttime diastolic blood pressure, it can cause diastolic dysfunction. The onset preceding left ventricular hypertrophy is consistent with observation that BNP levels grow gradually with progression of the diastolic dysfunction grading. Now, what is the, do these have any clinical relevance? Are these borne by clinical studies? In the Framingham offspring cohort study, the rate of death after 5 years in a person with heart failure and normal ejection fraction is 68%, whereas it is 82% in heart failure and reduced ejection fraction. Yes, it is lesser, but it is not negligible. 68% is quite high. But because you should remember that it is 4 times greater than people of normal left ventricle. A study by Hogg et al. Showed that mortality in heart failure, normal ejection fraction may be mild during the first year, compared to heart failure with reduced ejection fraction. However, it becomes equal after 5 to 6 years, mind you. It becomes equal to persons with heart failure ejection fraction after a period of 5 to 6 years. Badano's criteria used ESC criteria to identify diastolic dysfunction. They did not find much difference between heart failure and in reduced ejection fraction. Now, what is the prognosis? The PUMA study, which looked at the pattern of abnormal relaxation of E by A. This is a ratio that is in the mitral valve inflow. We look at the E, and that you get a ratio which is known as the E by A, and this increases the risk of cardiovascular events quite significantly. So it is a very good ratio. But if you look at this bar chart, all-cause death is increased in persons whose E by A ratio is greater than 1.5. At the same time, between 0.6 to 1.5, the all-cause death is lesser. But if it is less than 0.6, again it increases. Similarly, so for cardiac death. So the strong heart study on American Indian showed that a transmitral E by A ratio less than 0.6 doubles mitral mortality risk, And E by A of greater than 1.5 is related to a threefold increase of mortality. A threefold increase of mortality. Now, the Doppler indices from this Mayo Clinic study just shows the normal pattern. You can just for your information about when you look at an echo pattern, this is how a normal pattern looks. When you have abnormal relaxation, when you have abnormal relaxation, you find that the E is smaller than A. When you have pseudo-normal, the E becomes taller than A. It is not normal, that's why it's not a pseudo-normal. In a restrictive pattern, the E becomes much taller, and that is when it's reversible initially. In irreversible, the base of this narrows, that is the decelerating time shortens. So these are the various patterns of Doppler indices, what you see. Now, how do you treat these patients with diastolic dysfunction? The objective is to give a reduced salt diet and a moderate diuretic administration. Both ACE inhibitors and ARBs exert a beneficial effect as they reduce both pre and after load and induce regression of LVH and decrease myocardial interstitial fibrosis. Aldosterone antagonist spironolactone can also reduce myocardial fibrosis, and it should be considered. One of the studies that looked at diastolic dysfunction is the CHARM study, which looked at cardiovascular death or heart failure hospitalization, which found 11% risk reduction versus placebo for patients who were candy-certain. Although the p-values were not very significant, that did show 11% absolute risk reduction. So how do we treat persons with hypertensive heart disease? When a diastolic dysfunction is overt, patient is breathless, you have to control heart rate and reduce the tachycardia. For this, beta blockers and electrical extent, verapamil is quite useful. The newer drug, ivabradine, is very, very helpful. One advantage of ivabradine is that it will not affect the ventricular contractility. It will reduce the slow heart. It will reduce the heart rate. And it is a wonderful armamentarium when you're dealing with a patient with heart failure who has got a low BP but is tachycardic, and you need to reduce the heart rate. Remember, it should be used only in persons whose heart rate is greater than 80 or 90, and not for somebody whose heart rate is very less. So lower heart rates induce prolongation of LV filling time, allowing counterbalance resistance to diastolic inflow. Several studies like the carvedilol study, that is Swedish study, nebivolol seniors trial, showed that beta blockers with the vasodilating activity have got very good effects in patients with heart failure. Of course, you have got innumerable studies of the use of ACE inhibitors and in the effect in patients with heart failure, and perindopril, irbisa consensus trial with enalapril, ramipril, Hong Kong trial, and then you have got the SHEP study, which was conducted in elderly, I think in the UK. So all these trials are very good. I'm sorry. Okay, one of the slides, because this place is causing a little confusion for me. Now, therapy of diastolic dysfunction. New therapeutic fields for diastolic dysfunction and heart failure will be opened in view of association between the coronary microcirculation and LV diastolic function. A restored function of coronary microcirculation. Supposing you have got lesser blood flow in the microcirculation, and if you are able to restore the flow, it could improve the diastolic dysfunction of the hypertensive heart. Now, putting all this in a nutshell is this central illustration. A person with arterial hypertension, one has to look whether the heart is normal, whether there is a preserved ejection fraction or a reduced ejection fraction. The preserved ejection fraction person with arterial hypertension will have left ventricular hypertrophy, diastolic dysfunction, and preserved left ventricular ejection fraction, whereas those with reduced ejection fraction will have eccentric left ventricular hypertrophy, systolic LV dysfunction, and a reduced left ventricular ejection fraction. Now, the initial presumptive heart failure therapy would be to start the patient first on ACE inhibitors or ARBs, combine it with a beta blocker and a loop diuretic. A loop diuretic means that is furosemide or ethacrynate acid. And then if it is the BP, the symptoms do not improve, you can switch ACE inhibitors or ARB to valsartan plus sacubitril combination, what we know as the ARNI drugs. And you may continue the rest of the drugs, or you may want to add a statin. Going to the next stage, if there is no improvement, you should switch over from the traditional beta blocker to a vasodilating beta blocker like a carvedilol or a nebivolol or a bisoprolol also. And if the patient is a diabetic, or even in patients who do not have diabetes, you can add an SGL2 inhibitors. You know from the DAPA heart failure trial, which has come recently, that even in patients who do not have diabetes, but who have heart failure, who have hypertension, and SGL2 inhibitors like dapagliflozin may be very useful. Then, of course, you can add calcium channel blockers, spironolactone, thiazide-like diuretics in various combinations or at various times. So what I would like to give you as a take-home from this half an hour presentation is that in hypertensive patients, diastolic dysfunction and diastolic heart failure is common. Please remember that. Hypertension is not a silent disease. It progresses silently. You don't know until it comes and stabs the patient in the back. Diastolic heart failure identified by Doppler studies should be considered in presence of signs of heart failure and normal ejection fraction. That is EF more than 50 or more. Diastolic heart failure is associated with 4-fold increase in mortality. Remember that. Mortality expectation is lower than in systolic heart failure, but remember that the difference gets blunted after 5.5 years or more. So initially there may be that heart failure with reduced ejection fraction may have more mortality than your ones with preserved ejection fraction, but as time advances, both the mortality expectation becomes the same. How do you prevent? Better control of blood pressure. For better control of blood pressure, important to identify those with hypertension, important to make sure that the person knows about the importance of treating blood pressure, important to see that they continue to take their medicine and do not stop the medicine, and concomitant factors of hypertension patients should be seen. So thank you for your patient listening and for bearing with the interruptions. Thank you. So can I come back with the questions? And
thank you. Yes, thank you very much. It was a wonderful lecture, Dr. Joy. We really enjoyed your talk, and we will ask you questions. The panelists also there to supplement the questions. Can you stop sharing now? I'll go for another program. Another Kahoot. Yeah, you stop sharing, Joy.
Are you going for the quiz now or later?
No, we are going for the questions now, Kahoot, and then only we'll come to questions. You first stop sharing, Joy.
I'm doing it, sir.
Yeah, very good. Thank you. So, my dear brothers, it was a very good talk by our friend Joy. Now, as usual, before I go to panelists, let me go for the Kahoot. I hope all of you have downloaded that Kahoot app. Be ready. We'll play the game now. I'll give the game pin. And once I get the game pin, you can log in and start answering. We have 10 questions, each question 20 seconds. Now join, please join.
Yes.
Now the game pin is 2879271. The game pin is 2879271. Yeah, please. Those of you who have joined this time only, there is an app called Kahoot app. You can use in your laptop or in your mobile. Download the app and enter this PIN number 2879271. You will all set to play the game. There will be 10 questions. Each question only 20 seconds. Those of you who answer early will get more marks. And when we consider who is very active, all the Kahoots put together, we'll find out who has scored in all the 12 webinars. Last time we calculated, we'll give you the result of those people who continuously, constantly was first, second, third, fourth, fifth. I'll give you another 5 seconds. You log in, otherwise I will go for the game. Let's start with it. Last 2 seconds. I'll give one more second. then I will go for the game. Ready? Okay. Thank you. I'll start now. The interactive session. 3, 2, 1. Here is the first question. Significant left ventricular hypertrophy is present when left ventricular thickness exceeds 9 millimeter, 11 millimeter, 15 millimeter, or 30 millimeters. Good. Already in 10 seconds, 50 people have answered. Very nice. The correct answer is 15. Not bad. 41 people have answered correctly. Next. I think Sumit Vadua is 9:45, followed by Shiv and Yusuf, Nanda, and Pankaj. We'll go to the second question. In concentric hypertrophy, the wall thickness is increased and the lumen is increased. The wall thickness is increased all round and lumen is decreased. The wall thickness is increased in the interventricular septum only. The wall thickness is increased in the apex only. What is concentric hypertrophy? Good. 43 have answered correctly. The wall thickness is increased all round and the lumen is decreased. Now GS has got 1728, Atinda, Anand, Padma Shri, and Mahesh. I don't see Anil Virmani. I think is there. As per 2017 guidelines on hypertension classification, stage 1 hypertension is when systolic BP is more than 130 and diastolic BP is more than 80. I think you have some confusion. So 60 people have answered. Stage 1 hypertension is when systolic BP is more than 130 and diastolic is more than 80. This is the ACC guidelines. Of course, we have got now recently international guidelines and the European guidelines. There, there's a slight difference. But the question is 2017 ACC guidelines. Now, GS is Shiv is first, Nanda, then Yusuf Ali. We'll go to the fourth question. The Soplo-Leon criteria indicates LVH if the score exceeds 25, 30, 35, 40. Yeah, 20 seconds over. 63 have answered. Yes, 40. 40 people have answered. It's 35. Now the next question. Of course, Siva, then followed by Tushar. Yes. Now we'll go to the fifth question. By echo Doppler, a transmitral E bar A ratio more than less than 0.6 doubles mortality risk, more than 0.6 to 1.5 or 1.5 triple more mortality risk, or all of the above are true. Which is true? Correct answer is all of the above. I think now Shiva is still leading. We'll go to the next question. Sixth question. Beta blockers like carvedilol and nebivolol with vasodilator activity preferred in treating heart failure. True or false? Very simple. I think all of you should be right. Yes, 60 people are right. Correct. Now, still Shiva, Tushar. Now, the seventh question. Multi-select. Scoring system for assessing LVH in ECG is Soplo and Lane, Framingham, Romhill and Estes, or Cornell. Scoring system for assessing LVH in ECG. It is Romhit and STs. 25 have answered correctly. Now, Tushar leading, Atinda, followed by Karthik. The next question, 8th question. Major and ultrastructural determinant of diastolic dysfunction in hypertrophic heart is pericardial cells, endocardial cells, collagen extracellular matrix, or endothelium. Major ultrastructural determinant of diastolic dysfunction in hypertrophy of heart is 6 have answered correctly. Collagen extracellular matrix. Now we go for the score. Tushar is still leading, Karthi second. Now the 9th question. First choice in the pharmacological management of heart failure is statins, ACE ARB, alpha blocker, or coenzyme Q. I think this is a very simple question. I think all of you should be right. First choice. Good. Very nice. Good. Excellent. All these 66 who have participated have answered. Very good. I think, Joy, your lecture was excellent. Everybody answered correctly. Good. Next question, the last question. Ventricular relaxation is a passive process and does not require energy expenditure. Is it true or false? I think here also all of you must be right. Thirty-four have answered false. Okay, now we'll see the score. Who's number 1? Satak is the third. Q is second. And Tushar Vidale is first, 10 out of 10. Runners up, Yusuf and Magesh. Okay, that completes the Kahoot. Now we'll go to the panel. Yes. Let me have the pleasure of inviting our guest of today's program, Dr. Hani. Dr. Hani? Yeah, please unmute. Please unmute.
I'm now on mute and I can hear you.
Yes. Yeah, your words of wisdom on this particular topic.
Yeah, first of all, it's really amazing how informative lecture is and how engaged the audience and the candidate in answering questions, indicating that the lecture was very well received by all. So I'm delighted with that. It's, very important, highlighting the need for a public, that's what you described, Dr. Muruganathan, public awareness is very, very important. That I do have a question which is really important, that we talk about the left ventricular hypertrophy and impact of diastolic function. And perhaps we could ask, so far, the impact in left ventricular hypertrophy. Can you hear me okay, Dr. Muruganathan? Hello? Can you hear me?
Yeah, I can hear you. Please go ahead.
Okay, so my question and my point to the panel is probably, that the two issues. One is the silent killer, hypertension, in the majority of patients, at least at the beginning, does not produce any symptoms while starting the patient on medical therapy, could have side effects, particularly if we try to maximize the medication and dose. My question, how do you reconcile that with your patient? And the other question, which is more important, is the impact of medical therapy on left ventricular hypertrophy. So far, with very little impact on regression of
I think Dr. Chenniappan, are you there? Chenniappan? Chenniappan?
Can I answer this question?
Dr. Chenniappan?
Yes, sir. Dr. Joy wants to answer. Yes, Joy, go ahead.
Yeah.
Go ahead.
Just a comment. I mean, I don't think it's an answer to this. The question was that when patients who are put on treatment, do they have any problem in taking the treatment? Do they discontinue it? In my practice, I have found that whenever you are faced with a young person, let's say somebody between 30 and 40 years of age, and you identify him that he has got high blood pressure and put him on an antihypertensive drug, they are very much against taking this medication. And you write the prescription and they will come back after 3 months, 6 months with again high blood pressure. And when you ask them, have you been taking the medicines? More often than not, I find that they are not taking the medicines. Despite trying to educate them in the beginning, that because they all say, why are you writing this medicine? I don't have any symptoms. Then we try to tell them about antihypertensive effects. I have a chart in my table which shows all the effects of hypertension on the kidney, on the eyes, the heart, everything. I just show them all these effects, but still at the end of after 6 months or so at follow-up, they're still not taking the medication. Now, it's not because they are not aware of it, but they don't think about it too deeply and they are not convinced. It is not about money or anything, because some of the well-to-do people themselves don't take these medicines. Some of them, I'm not taking everybody. So it is a problem. Chenniappan, I like, you have got greater experience than me in cardiology practice. You please tell.
Joy, we are all classmates, you remember. So we are the same batch, and it's very nice to hear you. And it's a very good lecture. I congratulate you for all this good preparation and the involvement of the audience in the question answer session. The first time in the whole webinar series, the first time we had 100% right answer. That speaks volumes of your the lecture and also the understanding of the people. The question,
remember, you were my guru when I was in Trichy.
No, sir. No, we are all classmates and friends, Joy. The important question is whether the silent hypertension needs a treatment and whether the patient will be good enough to take this treatment for preventing future complications. So a very difficult question to answer, but a very practical question. But the problem here is that it has been shown that even the well-tolerated ARBs are taken only by 64% of people after the 1 year of your prescription. Only 38% take a diuretic therapy. So it's very, very difficult to convince an asymptomatic patient to take a drug with all side effects for the control of blood pressure. That's why we go into some investigation to convince the patient that he has got a silent disease. For example, if you do albuminuria and tell him that because of your hypertension, you are leaking protein in the urine, and you do an ECG and say, because of your hypertension, you have an LVH, and do a fundoscopy and say, because of your hypertension, already you have a silent eye problem. So these things will help us to convince the patient that because of the hypertension, although you don't have symptoms, you are silently suffering from some organ damage. So that is the way we can convince our patients to take drugs, of course, to prevent a future complication. And second point of drug therapy is the risk stratification. No longer we treat a hypertension on numbers now. So it is the risk of the patient to develop a future complication. So a low risk patient in grade 1 hypertension, try to do a lifestyle modification and do with a lifestyle modification and without no drugs, you can treat the patient. Whereas a grade 1 hypertension with the diabetes, CKD, or his risk score is more than 20% next 10 years. That means you have to convince him that the risk score is there. Now it is available in the mobile app. You can show him that his risk is, calculated risk is around 10 to 15% in the next 10 years if this hypertension is not treated. So they can convince him to continue the treatment. So these are the ways by which we can convince the patient to take the drugs properly. But still, the compliance and adherence rate is very low in our hypertensives.
Dr. Hani, are you happy with the answer? You want to add something?
Yeah, I think it's a very good answer, and I wouldn't add anything, but I would also emphasize the importance of public awareness and message on the media and and at local and national level That's number one. And number two is really, you will find it also varies in societies with the level of education, people who are more committed, the comments that has been made, just awareness and further explanation and patient education. Thank you.
Thank you, Hani. Now we'll go to the questions. Hamshankar Sharma has asked a question. What about the best drugs in young hypertensive heart disease with restrictive cardiomyopathy? Chenniappan, I would request you to answer this question. Best drugs in young hypertensive heart disease with restrictive cardiomyopathy.
Why me, sir, for this difficult question? So many panelists there. It's a very peculiar combination to have an younger hypertensive and restrictive cardiomyopathy. As you know, there are two different entities. So this is a combination of two different diseases. So many of the restrictive cardiomyopathy will present with congestion, backward failure. So the first drug of choice will be diuretics here, because many of them will have a high LA pressure and a high RA pressure. So usually they come with congestion. So the first drug is going to be diuretic. And second, if the patient and in hypertensive, we must always rule out a secondary cause. That's more important. So in this patient who has got a hypertensive, we must always rule out the treatable secondary causes like coactation, renal artery stenosis, or a primary hyperaldosteronism, and so on. So the next thing is, if the patient, most of the restrictive cardiomyopathy patients will have atrial fibrillation. So very common arrhythmia and restrictive cardiomyopathy is atrial fibrillation. So controlling the heart rate as well as the hypertension, if the patient is not in a gross class 4 heart failure, I next prefer a beta blocker to control the heart rate as well as to treat hypertension. If the patient has got significant congestion and significant class 4 heart failure, in those patients, the beta blockers may not help. Then comes the amlodipine. So amlodipine I will not prefer, because already the patient will have a huge edema. When you put the patient on calcium blocker, his edema goes to NPVs. Then comes angiotensin inhibitors. So the angiotensin inhibitors may not be helpful in a restrictive cardiomyopathy where there is no significant left ventricular hypertrophy or a left ventricular dysfunction, systolic dysfunction. Yes, a primarily stiff ventricle which is not dilating, which does not have a cause. So I'm left with a diuretic plus or minus beta blocker, and you can use some older drugs, like if the patient is tolerating a clonidine or some like drugs like the alpha methyl dopa, if the patient is going to accept. That's all the last scenario. But first drug will be diuretic, followed by a beta blocker if the patient is not in class 4 with the atrial fibrillation of the fast ventricular response. And these patients, if they have AF, always must have oral anticoagulants. So it's a very difficult problem to treat because it's a combination of two diseases.
Thank you, Chenniappan, for bringing that point. In a restrictive cardiomyopathy, the commonest arrhythmia is atrial fibrillation. So, Hamshankar Sharma, I think you got the answer. Now I'll go to Anil Virmani. Which patient of hypertension will have concentric LVH with diastolic dysfunction, and which patient will go into dilated cardiac failure? Any clinical indicators? Joy, you can take this question.
Yeah, like I said earlier, there are three scenarios of patient of hypertensive heart disease. One is the person with hypertrophy alone, and then if along with hypertrophy, this patient also develops ischemia, chronic ischemia or ischemic heart disease. For example, if he's also a diabetic, then the chances of his going into heart failure with reduced ejection fraction is much higher than the person who has got purely hypertension. And of course, the number of years in which he is having hypertension, the amount of hypertrophy is that also plays a part. So it all depends upon the amount of hypertrophy this person has, the amount of ischemia, because whenever there is hypertrophy, there is a demand-supply mismatch. The hypertrophy increases the amount of myocardium, which the capillaries of the heart may not be sufficient to provide blood for it. And this leads to chronic ischemia, and chronic ischemia can lead to increase in extracellular matrix fibrillar being deposited and increasing the diastolic dysfunction of the heart. So gradually, this diastolic dysfunction and this ischemia will make the heart dilate. And over a period of time, this person will go on into a dilated heart with a reduced ejection fraction. So it is a question of evolved how the person's disease evolves and what all concomitant risk factors he has, whether he also is a smoker, whether he is taking alcohol, which alcohol itself can cause dilated cardiomyopathy, as you all know. So these are various issues, various scenarios which we should analyze that particular patient is about. One thing we should not forget about is a person with a family history of premature coronary artery disease. So if you have a person with who has a family history of premature coronary artery disease, by which I mean is he has got a male member in the family with a heart who had a cardiac event, that is a heart attack or a sudden cardiac death at an age less than 55, or a female member with a cardiac event less than 65, then he can also develop these events like ischemia or arrhythmias. Atrial fibrillation is very important. Chenniappan just told about in patients with restrictive cardiomyopathy. It is not only restrictive cardiomyopathy. As I told in my speech, in my talk, a person with ventricular hypertrophy can develop atrial fibrillation. So if these persons have atrial fibrillation, and many of the atrial fibrillation are not diagnosed because they are asymptomatic, and if there is periods of the heart in which the tachycardia keeps going for a long time, they can go gradually into tachycardiomyopathy, which is one of the problems of atrial fibrillation. So all these things must be analyzed. So if a person with a hypertension is also having a reduced ejection fraction, he should be investigated fully and thoroughly for all this, with including a Holter, and also look at his risk factor profile and see that he gets a complete evaluation as far as diabetes, cholesterol, ischemia, coronary artery disease, everything is concerned.
Yeah, thank you, Thomas. No, that is why tomorrow we are having exclusively hypertension and atrial fibrillation by the stalwart Dr. Narasimhan, who is the authority on this.
Yes,
so he's going to have one full session on this atrial fibrillation. Okay,
yes,
Rajasekar.
one minute, sir. One minute, just. I think Dr. Anil is asking a clinical indicator of identifying a patient with hypertension who is going to go in for a heart failure with reduced ejection fraction.
Yes.
So we have three forms of hypertrophy. One is a relative wall thickness, what we call as a concentric remodeling, where the relative wall thickness is above 0.42. Then we have concentric left ventricular hypertrophy. Then we have eccentric left ventricular hypertrophy. So these are the stages the hypertension is going to produce left ventricular hypertrophy. I will say the clinical indicator will be, if you are clinically examining the patient, look at the apex beat. If the patient is going to have a heaving apical impulse and who is going to be inside your mid-clavicular line, you will have a concentric LV hypertrophy. If this, your serial clinical examination, if your apex beat is going to go down and out, that means he is developing an eccentric LV hypertrophy. And these are the patients who will ultimately develop a heart failure with reduced ejection fraction. So that is one of the best palpatory methods by which we can assess from a concentric hypertrophy, patient is going in for an eccentric hypertrophy, which is a pre-runner of heart failure with reduced ejection fraction.
Thank you, Chenniappan, for bringing that clinical point. Dr. Rajasekar. Rajasekar, are you there? Rajasekar? Rajasekar? Yeah. I saw a day for yesterday, you were giving an article on different types of hypertrophies. Inappropriate hypertrophy, inadequate hypertrophy, and so many hypertrophies. Can you throw some light on that hypertrophy?
This is classification by Cruikshank, sir. Hypertensive heart falls into three categories. The first and foremost is inappropriate hypertrophy, that is LV wall stress, that is on myocardial cell, that is low wall stress, inappropriate hypertrophy. Another is appropriate hypertrophy, that is a normal wall stress. Third is inadequate hypertrophy, that is high wall stress. The high wall stress with inadequate hypertrophy is related to high myocardial oxygen demand requirements, and the reverse is true for inappropriate hypertrophy with the low wall stress. The inappropriate hypertrophy is probably linked to neurohumoral factors and related to myocardial beta receptors where the response is increased. In contrast to left ventricular hypertrophy with a normal wall stress where beta receptor response is normal or rather decreased. So indeed, inappropriate left ventricular mass appears independent of blood pressure, which can be normal and may be a phenotypic expression of non-obstructive cardiomyopathy. So patients with inappropriate left ventricular mass are particularly prone to poor systolic and diastolic dysfunction, as Dr. Thomas has already highlighted, and in young and middle-aged hypertension is present to a great or lesser extent in about 50% of cases. Thank you, sir.
Okay, Rajasekar, thank you. And I think we'll send the article in the WhatsApp group tomorrow. Dr. Chenniappan, normally when we see the cardiologist give a report in the echo, grade 1 diastolic dysfunction. Is the treatment necessary for that grade 1 diastolic dysfunction? Chenniappan?
Grade 1 diastolic dysfunction, we find it in almost 90% of our echo reports now.
Yes.
So in future, absence of diastolic dysfunction, mitral valve prolapse is going to be abnormal rather than their presence. So the grade 1 diastolic dysfunction is primarily indicates that the left ventricle is stiff. The left ventricle is undergoing stiffness and it requires a lot amount of LA pressure. So now we have a risk stratification of grade 1 diastolic dysfunction, whether it is going to have a heart failure or it is a age-related hypertrophied stiffness of left ventricle. So in all grade 1 diastolic dysfunctions, you have to look at the tissue Doppler parameter, just like Dr. Joy told you, the E bar E prime ratio. So any grade 1 diastolic dysfunction patients who have got a E bar E prime ratio of more than 15 is a dangerous grade 1 diastolic dysfunction. So these are the patients who can suddenly go for a flash acute pulmonary edema, which is a very typical of heart failure with a preserved ejection fraction. So people who are less than 8, E bar E prime of less than 8 are supposed to have a normal left atrial pressure. These grade 1 diastolic dysfunction are low risk. When you have between 8 and 15, you must use other parameters like the left atrial dimensions or left atrial volume to assess whether the patient has got an additional increase in LA pressure. So now our advice is not only look at grade 1 diastolic dysfunction, but always look at E bar E prime ratio in that particular patient. Then we can pick up a high risk grade 1 diastolic dysfunction who have got the E bar E prime of more than 15. Now this is called grade 1A diastolic dysfunction.
But unfortunately, Chenniappan, not many cardiologists give this E bar E prime ratio in the echo report.
Yes, sir. In the absence of tissue Doppler, if you don't have a tissue Doppler and you have only a plain echo report, still it is possible. So what you have to look at whether the patient has got a significant left ventricular hypertrophy. And the most important thing, you have to look at the left atrial enlargement. An unexplained left atrial enlargement with a very high mass, left ventricular muscle mass. So this is an indirect evidence that the patient may have a dangerous grade 1 diastolic dysfunction. So look at the left atrium. In the absence of tissue Doppler, look at the left atrium. If it is unexplained, there is a dilatation which is unexplained because of mitral regurgitation. There is no mitral regurgitation. There is no mitral stenosis. So in spite of, in the absence, no restricted cardiomyopathy, in the absence of all the known causes of left atrial enlargement, significant LVH with a large LA is an indirect indicator of high risk grade 1 diastolic dysfunction.
Thank you, Chenniappan, for bringing that point. Dr. Hani, which antihypertensives lead to regression of LVH? Would you like to take this question?
Yeah, it's interesting because actually the clinical data does not show significant impact on regression of left ventricular hypertrophy with a superiority of one over the other. And this is an area that research is really focusing on significantly because we do not have convincing evidence. There are small kind of trials that shows, yeah, perhaps we do, others we don't. So we don't really have enough evidence to put conclusive judgment about the regression of left ventricular hypertrophy. Yes, we do control hypertension, and there are the guidelines tells you which patient to start which drug and when. Nonetheless, that the whole issue about controlling hypertension is not automatically resulted in significant or meaningful regression of left ventricular hypertrophy. So what we're doing is controlling hypertension, but we still haven't found why the impact of hypertension in the same magnitude of regression of left ventricular hypertrophy. And maybe that should be.
Okay.
And then I'm sure that there are a lot of groups worldwide looking at this research.
Okay. 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 Thank you. What Mahesh has asked a question, any one of you can take it. Athletic heart and diastolic dysfunction. Is there any correlation or connection between an athletic heart and diastolic dysfunction? Joy, would you like to take it?
See, athletic heart is a condition which causes arrhythmia, arrhythmic atrial fibrillation or sudden cardiac death in a person who need not necessarily have hypertensive, hypertrophy or anything. Even in a normal person, they can happen. But in a person who has developed hypertension and hypertensive heart disease, that person is at risk. That is why it is important for people who go for endurance training like marathon, long distance cycling, long distance swimming, or all those things, to have themselves completely checked, including a stress test and also a Holter testing to see if they have arrhythmias, which they may be asymptomatic too. So atrial fibrillation, ventricular arrhythmias, you can see sometimes some people collapsing and falling after a marathon is over, and then they die and nobody's able to resuscitate them. It happens on the football field, it happens in the swimming pool, it happens on the marathon runs. So it's important to do that. Other than that, the hypertrophy, which Dr. Chenniappan was alluding to, in athletes, it is not a concentric hypertrophy that happens. Many of them have an eccentric hypertrophy. So over a period of time, if these people do not take care of their health in the form of a good heart healthy lifestyle, they can go on to have heart failure eventually. So it is important for them to continue to do their exercise and to bring down the exercise level gradually rather than suddenly, and also take care of their other factors like diabetes, cholesterol, and stress, living stress, etc.
I think the sports coach should listen to all these findings. Okay. Is there any drug which is specific for hypertensive preserved ejection heart failure?
Preserved ejection heart failure, like was mentioned earlier in my thing, starting off with the diuretics or ACE inhibitors, ARBs, any of them would be appropriate. Apart from then subsequently you can add calcium channel blockers. Beta blockers is very important. That should be there in the first line of treatment. So ACE inhibitors, ARB, beta blockers, diuretics, then followed by the other drugs like statins. ARNI is a wonderful drug which is available now in patients with heart failure and with blood pressure and diabetes. SGL2 inhibitors like remagliflozin or dapagliflozin is very important.
How we should approach to systolic dysfunction in hypertension, and how is correlated with natural history of hypertension? Systolic
dysfunction, of course, after we treat the heart failure in the long term, depending upon how the ejection fraction is, how the person is responding to, because you have initially started treating the patient with the ACE inhibitors, ARBs, diuretics, all that. If the EF is very low and the patient is still symptomatic, I would add carefully digoxin for the patient and aldactone. Spironolactone is a useful drug, but of course in males, the problem of painful gynecomastia is very important. You have got eplerenone, which does not cause that much of gynecomastia, and that can replace spironolactone. Of course, the other measures like salt and fluid restriction are very important. Yes, Dr. Hani has something.
Yeah, Hani, please.
Yeah. So I think if we look at your figures that you really articulated earlier, 214 million in India will have hypertension in 2025. And the fact that hypertension is a very strong predictor for ischemic heart disease, etc., etc. Hypertension with severe LV dysfunction is very unlikely to be just a pure hypertension. It has to be very long time and advanced, hypertension. But you will find that as a combination of ischemic heart disease, arrhythmia, and other comorbid conditions. Also, people are overweight, so you will find a significant proportion of people who are hypertensive are also diabetic. So it's a holistic approach to the management type of patients. So, hypertension is unlikely to be happening in isolation, or hypertension with severe LV dysfunction, very unlikely to be happening in isolation.
Right.
So thank you, Dr. Hani. No, normally for a renal problem, the nephrologist always refer the patient to the eye doctor to find out the retinopathy. Does retinopathy also correlate with any one of you can take that question?
I'm not aware of any study.
Chenniappan?
Well, retinopathy, it's more, severity of hypertension, but not as a prognostic parameter as such.
Okay.
The hypertensive retinopathy is an indicator, and you have hypertensive retinopathy indicator of a microvascular problem in addition to the macrovascular problem. So that is an indirect evidence that your microvessels are also getting affected because of hypertension. So that is an indirect clinical clue.
Yeah, because most of the nephrologists, they also send the patient to the ophthalmologist to find out whether they have any renal involvement by correlating with the, in fact, I know before they develop any atherosclerosis elsewhere, they have a erectile dysfunction. That is also an indication that they're going for some atherosclerotic disease. Yeah, role of BNP in hypertensive heart disease. Role of BNP in hypertensive heart disease.
So it's one of the useful clinical application of BNP is when you have a young person coming in with breathlessness, and many of these people say that he has got blood pressure, but he also has wheezing. He is known to have episodes of asthma. So in such an acute situation with a person with acute breathlessness, a BNP value is very useful to find out whether it is a cardiac or respiratory thing in order to initiate the appropriate treatment in this patient. And having said that, high BNP is a good indicator of the risk that the patient faces from any further cardiac event. And its value is very important in order to decide whether the patient has heart failure or purely respiratory.
Okay. Do we have a normative data of LV size, LV mass among Indian population and gender?
I do not know. I mean, there may be.
Okay.
I don't think we have, sir. We go with the Western guidelines of deciding LVH by LV mass of more than 114 in men and more than 95 in women. We go with that only. I don't think we have Indian standards to diagnose LVH by echocardiography. We go with the Western echocardiographic mass index numbers.
Any method of finding out who are likely to have sudden cardiac death in hypertensive hypertrophic heart disease?
Heart is normal. It is only related to having a family history of sudden cardiac death. It's found more in Southeast Asian males and all that. So that is a different entity. Whereas in persons with hypertension, like I mentioned earlier, anybody, we should assess a patient whether this person has had, because one thing one must remember is that many of these arrhythmias, particularly VPDs or APDs, which trigger these arrhythmias, are because of ionic problems. And this are linked to genes. For example, the gene abnormalities related to gene SCNA is one thing. So KVNQ, as is seen in long QT syndrome. So we have to see whether these things are there. Has the patient has long QT syndrome, does the patient have these type of genetic? But doing gene sequencing also does not help. So what we have to do is do Holter studies, find out if the long-term Holter over 24 hours, ambulatory Holter picks up any VPDs, any complex things like couplets or short runs of VT. These are the only things which are available now. Even after doing all these things, of course, a treadmill will help in all patients who are going, like I said earlier, for any endurance sports, whether it is marathon, swimming, or cycling. They should have a treadmill as well as a Holter. And if you have features of ischemia or ventricular arrhythmias or atrial arrhythmias, they should be investigated further. If necessary, angiogram, if necessary, invasive electrophysiology study should be done for them. Because who knows, you may be preventing a sudden cardiac arrest in these people. That's the only way available now. The other thing is by prevention, by establishing automatic defibrillators in various places like airports and this and that. That is given more to NGOs and governmental organizations. And right now we are seeing many of them positioned in airports and things like that.
Chenniappan, would you like to add any other point in this question?
No, sir. Joy has already answered, but what is the substrate for developing this malignant ventricular arrhythmias in LVH is fibrosis. So when the fibrosis happens, there is a differential refractory period within the myocardium, which predisposes to re-entry and dangerous things happen. So if you're able to detect, for example, all hypertrophic cardiomyopathy patients are not going for sudden death. And that's why now it is very important to do an MRI, cardiac MRI, to see the late gadolinium imaging and see what amount of fibrosis this patient has got. Similarly, if the patient has got an LVH and the patient has got some sort of predominant symptoms, like he had already one episode of syncope or a pre-syncope, he has got an LVH, hypertension. This is the patient who has to be investigated for either the fibrosis through. We can also have some idea about speckle tracking. Images will tell us the amount of longitudinal function, and cardiac MRI will tell us what is the amount of fibrosis we have. So the LVH patients who got a large amount of the gadolinium scanning uptake in their ventricles are maybe the candidates who can be prone for a sudden death.
Thank you, Chenniappan. Dr. Hani, do you use polypill in your country for hypertension? Polypill?
Polypill. We normally, it's kind of sometimes popular in North America, but where we are, we rely on the generic individual, pills, not the polypill. It's not really kind of a very commonly used.
Role of colchicine in hypertensive heart disease. Anybody? Do you use colchicine in hypertensive heart disease?
No, colchicine is a predominantly an anti-inflammatory agent. So we don't have any specific indication to use that in patients with hypertension. But Rajasekar, you can say something.
Because why they are asking, there is hyperuricemia associated with hypertension. There is a recent article, colchicine can be used. That is why they are asking.
For uric acid or hypertension, sir?
Hyperuricemia associated with the systemic hypertension.
No, the treatment for hypertension or uric acid?
Uric acid. Because it is associated with the systemic hypertension.
Okay, right.
Okay. So they may ask also allopurinol.
Yeah,
What is the use of allopurinol also? They can ask that.
For gouty people who have arthritis.
Yeah. It's a not direct impact on hypertension. Associated diseases, it can. I think there is it's one of the indications to use, compelling indication to use that drug.
I think we have got another 35 questions. I will stop with 3 more questions. What is the drug of choice in persistent mild diastolic hypertension in a younger person? And what will happen if you don't treat?
Diastolic hypertension, I think calcium channel blocker is useful along with the diabetic. ACE inhibitors, ARB should also have been already there because you are talking about persistent diastolic. So I presume this person is already on ACE inhibitors or ARBs, and then you're going to add a drug. You're going to add a drug and the patient already has got ACE inhibitors, ARBs, that calcium channel blocker with the diuretic. But if the person doesn't have ACE inhibitor ARB, that is very important to add.
Is there any specific drug for younger people we use in India?
Younger people, certainly I remember Chenniappan's talk when the person has only hypertension and no ischemia or other thing, beta blockers should not be used. So I think we should avoid beta blockers in any young person because that will really make them very, they will not tolerate the drug. You know the reasons, sexual dysfunction as also, it makes them feel very drowsy. I mean, takes away a little bit of their energy. That's what they say. I normally put these people, although I know that ACE inhibitors are the best drugs, I still go for ARBs. The reason is, I put a person on ACE inhibitors, these people have cough or something, not all of them, but then they immediately stop the drug because I am having this cough. So maybe it's only 20-30% who have got dry hacking cough, but they stop it. We do not know who the 20-30% is. So right now, since you have got ARBs, which have got equal effect like ACE inhibitors in all aspects of hypertension and heart failure, I prefer to use ARB. There are n number of ARBs available. So for a young person, an ARB is what I prefer in my treatment. Now,
but Joy, for a young lady, you cannot do that. No, for a reproductive age young lady, what is that?
Of course. So when the person is having a pregnancy, that time you need not. But if the person is not pregnant, you can still go ahead with the ARB. Of course, whenever a young lady comes of reproductive age, it is important.
But you know, but in India, Joy, in India, we have an Indian heart study where we are all more sympathetic overactivity and then we have more heart rate. So people in India,
I was about to tell that when you continue. See, there are some people who are very anxious, and the moment you see them, you find that their heart rate is very high. When you touch them, the hands are very cold and clammy, sometimes even sweaty. In such people, I have straight away used beta blockers straight away, although they may not have ischemia, or mainly to reduce their sympathetic overdrive.
Okay, Dr. Hani?
There are two parts of this question. One is you should treat with what drug? Should we treat at all? So these are the two parts of the question. First question, should we treat it at all? Is regarding the risk. That's why I told you no longer the treatment of hypertension is not on numbers. It is a risk of this patient to develop future event. So you have to risk stratify the patient, associated risk factors, hypertension mediated organ disease. If any of these things are present, you need to treat. Second, the drug of choice usually in less than 55 years is ACE inhibitor, A or B, ACE inhibitor or beta blockers. Because most often in young people, the hypertension is higher in. So because of that, you use the drugs like ACE inhibitor or ARB or beta blocker. So my take on this will be, if you want to treat a young male with a diastolic hypertension, it will be ACE inhibitor or ARB. It is a young female, it will be a beta blocker.
Yeah, that is why I asked that question. Fine. Thank you, Chenniappan. Hani, your comments, anything you would like to add? You unmute, please, Dr. Hani.
Thanks very much, Dr. Muruganathan. Yeah, just very briefly, it is clearly what we have in our hands now in treatment for hypertension is not the ideal final product. And that is why there are a lot of research about intervention like renal denervation and despite the disappointing results and the theory that the renal denervation could be good something for persistent and resistant hypertension, it didn't really produce the goods, although there are other new research doing. So the arena and the domain in hypertension treatment is still wide open for further refinement and further clinical research. And who knows what's ahead of us in the future. We started by sympathectomy, just to treat hypertension, and we are now having an absolutely great amount of medication and classes of different medication. But this is not the end of it. I think the future is still there for more refinement in the medication, and who knows, intervention might be adjunctive to pharmacology. Back to you, Dr. Muruganathan.
Thank you, Dr. Hani. Rajasekar, kindly note down all the questions. We will try to answer all the questions tomorrow in the WhatsApp because we have no time. So I think your final word from Rajasekar, your message for the day.
As Dr. Thomas has pointed out nicely, the assessment of ECG by LVH, that is the criteria. That is, one is Sokolow line and also coronal voltage criteria. there is one more important criteria is Pugro-Lopresti criteria. When other criteria are not met, we can apply this Pugro-Lopresti criteria, that is deepest S wave in any of the leads and S wave in V4. That is both added together should be equal to 3.3 millivolt in females and 2.8 millivolts in males. That is the point I want to highlight. That is a Pugro-Lopresti criteria.
Thank you, Rash. Thank you, Rash. Dr. Chenniappan, your final word.
What is very important here is to detect hypertension at the earliest, treat hypertension with adequate drugs and lifestyle modification, and prevent hypertensive heart disease rather than treat one.
Thank you, Dr. Chenniappan. Dr. Hani, your final word for the audience. Dr. Hani?
Sorry, I didn't catch that.
No, your final message to all of us.
Yeah, my final message, first of all, about hypertensive heart disease, there are a lot of it still we need to know and learn and develop and refine in our investigation and drug management and combined with intervention. And for this event, I am truly, truly impressed by the quality of the discussion, the organization, and the content, and also the engagement from our young and experienced colleagues to stay here. I read it's almost 300 participants participated in this. I thank you for associating me and the Royal College of Physician Surgeons. India is our absolutely top priority in our international activities. We're very proud of our partnership and our collaboration with you. You've got huge history in medicine, from healing to other medication and herbal medicine, and I am very grateful for being associated with you all, friends and colleagues tonight. Thank you.
Thank you, Dr. Hani. One word of more information. There are a lot of people who have joined through Facebook, also through YouTube. So totally now 700 people are watching the program. Few are in the YouTube, few are in the Facebook, apart from the direct link. And what we do normally, all the questions which we have got, if we have no time to answer, we have got WhatsApp groups, 3 WhatsApp groups. So tomorrow we'll take up the question and we'll answer those questions there also. So that's what we do normally. Joy, final word from you, Joy, as a speaker.
I think I can't add more than what Dr. Hani and Chenniappan said. Hypertension is a silent killer. Like you, Dr. Muruganathan, quite right, set the ball rolling at the beginning of this talk, of this session. It is a silent killer, and we have to diagnose it as early as possible. How early to identify blood pressure? Various groups are working on it. Some have suggested as low as 18 years of age, because it has been found that in pediatric people also hypertension is there. So once it is diagnosed, educate the people, treat the people, and make sure that they continue to take the medicine and do not abstain from the drugs. That is very important. Make sure that the patient are prescribed affordable drugs and the things which they can buy and they can continue to take. If they cannot buy it, direct them to a government hospital where they can get it free of cost. That's what I do. When patients cannot afford it, I write medicines which is available in the government hospital and tell them go there and collect your medicine. So it's important that they continue to take the drugs, because you'll be doing them a favor, not only them, the country also, because if you save people from heart failure and other, you'll be saving a lot on medical health care.
Thank you, Dr. Joy, for the wonderful talk. And I think I will also have the opportunity to invite you to join us, our WhatsApp group, so that you can also contribute. We won't disturb you regularly. Maybe whenever you check in, you can always answer a few questions when you type in. Yeah. Okay. And we also have one topic on pediatric hypertension in the program. We have a pediatric hypertension talk also. One pediatrician and one cardiologist are going to talk on this. So I take this opportunity to thank especially Dr. Hani Etiba, who is my good friend. He's the Vice President of Royal College of Glasgow, and he's an interventional cardiologist. Thank you for beginning. This is the first program. So we start with a bank with Rohit Sharma, Joy Thomas hitting sixers, and then you were being also there. And of course, our usual Virat Kohli, Chenniappan is there, and Rajasekar is there. I'm only a coach like Sachin Tendulkar, retired, and only making people to talk. I'm listening. So thank you very much. We'll see you tomorrow. We same time, 9 o'clock, hypertension and the rhythm disorders, atrial fibrillation. There is one Dr. Narasimhan from our country, Dr. Annie. He's one of the famous electrophysiologists who has done a lot of work on electrophysiology. He's going to talk to us on hypertension and rhythm disorders, especially atrial fibrillation. See you guys all tomorrow. This is Dr. Muruganathan, Governor, signing off from all of you. Take care. Namaste. Good night. Thank you all. Thank you.
Thank you.
Thank you.
Thanks, Dr. Muruganathan.
Thank you all. Thank you, Doctor.